Hi, Darla.
Hi there.
Hi, Lisa.
Hi. Jeez, my phone is going nonstop.
I just.
Hi.
Hi.
Hi. No, nobody is here yet.
Where is here?
What was that again?
Where is here?
Gardner Adult Education.
Okay, thank you.
We're not doing stairs. So I don't know if the person's coming or not, but we're on. Now I can't see you plainly. I don't know exactly what I need to do.
It would have something to do with the video. Are you using a Tandberg or a laptop?
Yeah, Tamberg. I can see you now on the top one.
Okay,
Yep.
I can't see you at all.
You can't.
No.
Do you know what I need to do?
Use the.
I've got the remote.
No, I don't.
Oh, gee, Diane's gone. Well, I don't think we'll worry about it unless the person shows up.
Okay.
Okay, so I'm going to leave the room, and if the person shows up, I'll be back.
Okay, great.
Is that okay? Thanks.
Fine, thank you.
Yep.
Was he off last night?
Strange how that happens.
Yeah, there's gonna be some silence.
Because it worked for the first few weeks.
Oh, no, she just moved through.
How's it looking on the head pick books?
We got an email that said they're sorry for the delay, but they're actually supposed to be shipping out next week.
Cool.
Why would he tell me that? Today?
Well, the best part was usually in the middle of the season. Is the other still taking this class? The one who she's in homeschool?
Yes, but her husband is something to do with a truck, so she's missed the last 2 weeks of class.
Okay.
It's frustrated.
I did the medical terminology class online with her before this one. I didn't know if I was going to make it. I made it here though by the skin of my teeth.
You wanted you to write him a note?
No, just call and have him dismissed. so welcome everyone. We are on, I believe, week 11. Is that correct?
Ouch.
Sure, we're on week 7. So,
Gardener's here, no picture.
I see that, Angel. I'm sorry. It's the school has to figure out what's going on. It's not.
Oh, it's at the school.
Hi, I am here, but I do not know how to, and I should.
There's somebody here looking at it, but
Yeah, they can see, we can see you, but you
Okay.
can't see us.
No.
then that's how it's been. But
It is?
it hasn't been showing any picture
Oh.
for at least 4 or 5 classes now. It's been
Okay,
since they had
has it
problems
been
with the
like
bird,
this?
the bird deal.
Oh,
Yeah,
okay. Is this okay with you?
yeah, that's fine. with
Is
me.
this okay to, continue like this?
It's
But she
okay.
can see and hear you.
Yes.
Okay, thank you. Is that okay?
Yeah, thank you.
All right. If you have any problems, let me know.
Yeah, all right.
Maybe I can help you, but.
So tonight is week 11, chapter 13 and 14 in our book. And chapter 13 is all about our CPT codes. And chapter 14 is about modifiers. Now I know that we are still waiting on HickPick books, and we received notice from the publisher this week that those are supposed to be shipped out the week of the 19th. So I believe that is next week. And as I told you when we started this class, that is the hardest part with the class being held this time of year, is that the publishers have such a demand for the books, not only because of the classes, but because of coding in general and people purchasing the books for their job, that we end up having this problem. So the HickPick book itself is not a huge issue. And Noble, if you want to just shut the Tandberg off, you can do that. We're not going to end up using the HickPick book a lot, and whatever exercises you do have for the HickPicks, you definitely can go back and use it, okay, afterward. It's not something that's going to cause big problems. So we're going to finish up with the answers for chapter 12 in the workbook, because I told you we finished off on number 44. On page 67 in the workbook. So they actually tell you where you need to look for the codes for number 44. So for letter A, you would have 96509. That would be for the codeine poisoning. And then you would have an E code, which is the E850.2. And why would we have the E code? Because of the poisoning. And it was an accident. Codeine poisoning. They consider that an accident. Letter B, you would have 965.4 and E850.4. Again, an accident. Letter C, 980.0 and E860.0. Letter D, lethargy, 780.79. Letter E, vomiting, 787.03. And F, 789.0. Actually, 789.00. All right, so 46, 790.7 and 041.7. 48, 922.32 and E 85.9. 50, 998.31. 52, 533.40. 54, 569.62. 56, 617.1, 617.3, and 58, 625.6. Number 60, 786.50. Number 62, 684 and 373.5. I'm sorry, 62, 684 and 373.5. Number 64, 756.52. Number 66, 715.33. Number 68, 883.1 and E920.9. $70, 786.09. 72, 733.13. 74, 9.4.20. And you're going to have an E code here for the burning, E899.
Could you repeat that one?
944.20 and E899.
Thank you.
You're welcome. 76, 943.20 and E924.0. And on either one of these, you would not use 948 because it didn't specify the percentage. 78, 996.73. 80, 915.6 and E920.8. 82, 770.87 and 84, 790.22. Did any of you retry the reports?
I couldn't understand how to even do them.
Okay. So let's look at 86. 86 is report number 8. And if we turn to report number 8 in the back of the book, it says, so, this is an operative report. When they give us the pre and the post-operative, we're going to code based on the post-operative diagnosis. Now, it is a multiple sinus tract, one extending inferiorly about 7 times 3 centimeters in diameter, one extending to the right approximately 4 times 3 centimeters, and one 4 times 3 centimeters extending to the left of 4 times 3 centimeters. The surgical findings as above, plus the non-granulation tissue present in a capsule of multiple sinus tracts. Sinus tracts measured a total of about 15 times 8 centimeters in their total dimensions. The surgical procedure, partial unroofing of sinus tracts. This is a full thickness debridement. For the anesthesia, it's a general endotracheal. They give you a description for the procedure. This patient was intubated and turned in the prone position. A probe was inserted in the sinus cavity and dissection was carried down to this. I encountered a piece of chronically infected granulation tissue coming out of a hole in which I stuck the probe, but this continued for a distance longer than the probe, and accordingly I put my finger in this. This extends down the length of my index finger. Can you move to microphones, please?
Could somebody tell me where the reports are?
In the back of the workbook.
What page? Oh, the workbook. I'm looking at the regular book.
Page 213 in the back of the workbook.
213.
213 is report number 8.
All right, thank you. All right.
And then it goes over to the next page, 214. Code is queried. It is unclear from your documentation exactly what the procedure was the physician performed. So the coder queried the physician and asked for additional information to ensure correct coding. The physician explained that the patient has a recurrent history of pyogenic granuloma of the buttock with sinus tracts that have, as in this instance, required a subcutaneous tissue debridement. So the preoperative diagnosis is a pyogenic granuloma sinus tract of the buttocks. And they told you what they did for the postoperative diagnosis. They told you what the procedure was. Basically, what we're going to code here first is a fistula of the skin. And then the secondary diagnosis would be the granuloma. What kind of granuloma? It would be a pyogenic granuloma. So go ahead and look up the first one, which is a fistula of the skin. We'll take a minute just to do that one. Start with fistula. right, so Emily, what did you come up with?
686.9, but I didn't even compare it.
Yep,
That's what I've gotten so far.
That's fine. Lisa, what did you get?
686.9.
Okay, Barbara? I'm sorry, Darla?
686.9.
And Angel?
686.9.
Okay, so how did we know it was a fistula?
You told us.
Yeah, because I've been looking for
We
it.
didn't find it.
I know it's the terminology I'm not reading.
So
I
it
had
would be-
fistula written next to it, so I must have tried to look for it there at some point and trying to find the answer.
Yeah, because we have a granuloma, and they talk about granuloma plus benign granulation tissue present in a capsule. And they go down and they talk about the granulation tissue, infected granulation tissue coming out of a hole. So we have a fistula, okay? And then a granuloma pyogenic, the diagnosis code for that would be 686.1, if you didn't get that. All right, number 88 is report 11. Report 11 is a bulky free flap of the right heel. And the post-op is the same. The procedure performed is defatting of the flap of the right heel with excision of redundant skin. So when you read that, what do you think, Lisa?
This Lisa?
There's only one Lisa on tonight.
Oh, okay, sorry. Maybe redundant.
Okay, how about you, Darla?
Excision?
Excision of what?
Heel.
Why?
Oh, you were down that far.
That's the subject of it.
Mhm.
That would be the main term, is what I was
Emily, what
pointing
do
out.
you think?
They're having something removed. I'm just trying to figure out what, or not removed, but they're.
They are. They're having something
I
removed.
don't know if
It's a bulky free flap, okay? So when you hear bulky or defatting of a flap, they're removing excess skin. So
You said, sorry, you said bulky, or what was the other word you used?
defatting the flap,
Deflatting.
defatting.
Defatting, okay. Defatting.
Yep. So they're removing the thickness of the flap. So, I mean, we all know that our heel is pretty smooth, right? So if we have an extra growth on our body somewhere, it's going to be excess. Okay? So in this instance, what we're going to start looking up, so next to bulky free flap, you might want to write excess. Okay? And it's an excess of what?
Flap.
It's an excess of skin.
In.
So go ahead and look up excess skin and tell me what you come up with.
701.9.
Does everyone concur on that?
Yes.
Darla?
No, I can't find the excessive skin there.
So it'd be excess, find excess first.
Okay, I got it now. Excess. Okay, 701.9.
Yes. Emily?
701.9.
Okay. All right, so this is where we do the detective work. All right, this one isn't pretty clear cut. So you have to ask yourself, what are they doing here? It's obvious that they are excising. What are they excising? The flap on the right heel. Well, if you think a flap of something and they're telling you that it's a bulky free flap, it's either someone had a free flap attached or has a growth of something. It's not normal, okay? So you have to read these things and be a detective. You have to ask yourself questions like, what are they doing? And as we get into the CPT book, you'll recognize that everything has a procedure, whether it's an excision, an incision, a debridement, an introduction, all those things. And you don't know that stuff yet, okay? But for the diagnosis purpose, what were they doing? They were removing extra fat. What is extra fat? Excess. Excess what? Fat is what? Okay, these are the types of things you have to be trying to pull out of what you're reading. All right, let's do 90. Report 13. All right, report 13 is on page 216. And this is a steroid injection. Now, the indication is that it is a left shoulder bursitis, rotator cuff syndrome. Then they go on to the preliminary report and the operative report, and then they go over to the lab report. And they tell you, see report 59, and then you have to go over to report 59, which is on page 245. So then you read the lab report and it tells you that the muscle biopsy of the left deltoid, the indication is that it is lipoma. They received it in a container labeled muscle biopsy. The skeletal muscle of the left deltoid shows normal morphology. Muscle biopsy, left deltoid, no pathological diagnosis. So with this report, this lab report, we don't have to do anything with the lab report because it's no problem. Okay? There's no real findings. So what we're going to code here is the indication. The indication would be like the diagnosis. Okay? So that's the other thing you have to pay attention to when you're reading these reports, is what do these words mean? You know, pre and post-operative diagnosis is pretty straightforward, but indications is a type of another word for diagnosis. This one is pretty straightforward. What are we going to code? We're going to code bursitis. Bursitis of what? Of the shoulder. So go ahead and look up bursitis of the shoulder.
I won't say it out loud.
Not yet.
No.
Doreen, I had number 90 circled also. Guess I got
Okay.
it from there. Did you say 90?
Yes,
you're
we're doing 90.
doing 90. And 91?
91, the answer's in the back of the book.
Okay.
So 90 right now, you're supposed to be looking up bursitis of the shoulder.
Okay, yep. I got it, yeah.
So Emily, what do you have?
726.10.
726.10. Lisa, what do you have?
726.10.
Darla?
Yep, the same, 726.
Angel?
726.10.
Okay, good. All right. 91 is report 14. Darla, you had a question on that?
No, I was just kind of concerned where you went to the lab report.
Only because, oh yeah, you're right. Good
Okay.
pickup.
Okay. Thank you.
You're welcome. It's late. It's been a long day.
Yes, marshmallow fluff, yes.
All right. Number 92 is report 15 over on the next page, page 217. All right. So when they give you these big long ones, you're going to look for the pre and post-op diagnosis and what's the procedure performed. This one, they're telling you it's a left distal radius fracture. So where are we going to start?
Fracture.
Right at fracture. What kind of fracture?
Radius.
Radius. And what is radius? What part of the body? It's actually a lower extremity. Okay, the radius is the lower part of an extremity. So I want you to start with fracture of the radius and lower end extremity. Because it's telling you left distal radius fracture. I really need to change that clock.
You can't kick this cold, can you? No.
Do you have any Subaru Outback?
I do.
Could you just move it over to the other side? That's actually a fire lane for fire trucks.
Oh, I'm sorry. Yeah.
And we're trying to get people not to park there anymore.
Okay. Sorry.
Thank you very much.
Don't go that way for him. I don't want you to trip. All right, what do you have for that one, Darla?
I don't have it yet.
Okay, Angel?
813.81.
Lisa?
Did you want me to tell you both of them?
No, just the first one.
813.81.
Nope. It's not 813.81.
It's not.
No, why is that?
What is it then? 813.81. Distal. Gotta be on the distal thing.
Oh,
Oh, I see what I did.
813.40.
42.
Yep. See?
Yeah. Didn't go back far enough.
Right. 8, 13, 42, because it's not a loan. It's not just a loan. And
And we
I
were
said
looking at the
lower
close.
end. Okay. And sorry. And we have an E code here because why? If you read the indications, why would I have an E code?
Because she fell down on the flight of stairs
Right. So how are we going to look that up?
under fall.
Right. And fall from stairs or steps.
Yeah.
So starting your E code index. Because we have a separate E code index, right? We're just doing the second part. The first answer was 813.42. And now we're looking up the fact that they fell off the stairs. So we're
See, and
going to E code index.
I feel like I have to go through it page by page by page.
Nope.
So I should be looking right at the index in the front here where the E codes are, and it should tell me where I need to be.
Right, because if you look in your E code index,
So, so
it would be fall. Right?
Okay,
Go to
say that
fall.
one more time.
Go to fall. So underneath fall, obviously. Fall
What
from
page is-
what?
How'd you get there so quick?
So page 1779 starts the fall. And where did they fall? They fell from what? They fell from off of stairs.
Okay, so you started in the
Yeah.
index, then went to the tabular part in the E.
Yes. Yes. So if I look on page 1780 in the index, fall from off of the steps,
Oh, I looked
which
at the
tells you stairs and steps, E880.9. Seven, 1780.
so I'm in the wrong.
You want to start in the index first because the E codes have an index. And the E code index starts on page 1763. I had you tab it.
Let me just see. Oh my God, I have to be blind.
So then you got stairs and steps, E880.9, right?
Yep.
No, I
then you
can't even find fall.
All right, so who said that?
1780.
All right,
The
so
page.
look on page 1780. Actually, start on 1779 in your ICD-9 book.
1779.
Bottom right-hand corner, fall.
This is, oh, right here. You're looking under, it'd be under accident then. Right?
Well, it says fall from, off. I don't know where you see
I don't-
accident.
I think I'm in the right place now. I think the light bulb just turned on.
Okay,
Yeah,
So-
it did.
so from off, and then, yes, from here, you have to go down through because it does list it alphabetically. Where did they fall off of? So a chair, a car, motorized, keep going over to the next column. They fell off of the stairs and steps. And that brings you over to the right-hand column on page 1780. And you see steps or stairs, E880.9. And then you go into your E code tabular and you look up the E880.9 to confirm it. And E880 is fall on or from stairs or steps. And then E880.9 is other stairs or steps. And in the exercise, it tells you that she fell yesterday down a flight of stairs.
And why would it be 0.9? If the explanation was stairs or steps, the 880.
Because when you see the 880 in a red box, you have to
Okay.
add a fourth or fifth digit.
Gotcha. Yep. It's dark in here.
That's okay.
I
Thank
wanna
you
know who
very
come up-
much.
You're welcome.
Who comes up with all those items where you can fall from? Jason.
I don't know, but take
That's a lot of
time to
things.
read through it and you'll be amazed.
Yeah.
You know those little, those sneakers that have wheelies in them?
Yes.
Heelys, okay? There's actually an E code for that.
No kidding. That's funny.
So number 92, report 15, you should have 813.42 and E880.9. All right, number 94, report 31. That would be on starting on page 229. The pre-op diagnosis is hematochezia. The post-operative diagnosis is 2 small polyps in the cecum, ascending colon, hot biopsied off, a small rectal polyp, hot biopsied off. The indication here is that this 46-year-old white male with Tourette's and some MR who has some hematochezia. There are no risk factors with no other symptoms. They tell you their findings. There are 3 small polyps, 2 in the cecum, ascending colon area, and 1 on the rectum, hot biopsied off. The plan is, if the polyps are adenomatosis, the patient should return again in 5 years for surveillance. Then there's a pathology report that you would read on page 56. So turn to 56 and read that. What does it say, Emily? Are there any findings?
Specimen was submitted, but it says the measurements of it and everything.
Okay. So for this, what we want to look for is the fact that the patient had a neoplasm in the intestine, and he had it in 2 places, the large colon and the rectum, and it was benign, and then he had a neoplasm in the cecum in the large intestine, which is benign. So you would actually code both of those because you have 1 in the large intestine, colon, and rectum, and 1 in the cecum in the large intestine. They're both benign because the pathology report indicates such, correct? Mm-hmm. So look up the first one, neoplasm, intestine, large colon and rectum, benign. And this is where your terminology comes in and your AMP knowing where to find these. Because in the exercise it doesn't say intestine, but you should know colon, cecum.
I'd be curious if I think that's right.
Doreen,
Yes.
I don't understand why you say that it's benign.
Did you look at the pathology report, number 56?
Yeah, I'm on page 244, number 56.
Cecum and ascending colon biopsies, mucosal hyperplastic polyps. The cecum and ascending mucosal fragments show glands that are vary in size and configuration and are lined by uniform epithelial cells. Hyperplasia of the glandular and surface epithelium are prominent with serrated architecture is evident. They received in a container labeled cecal ascending polyp. There are three fragments. The specimen is totally submitted. The history is adenoma and a specimen received with the cecal ascending polyp. So if they have here,
I mean, yeah, I'm right there with you. I just don't know what. Would it be because of the word epithelial? I mean, is that how you're assuming that it's benign?
one moment. Oh, plan if the polyps are adenomatous, the patient should return again in 5 years for surveillance.
Back from the other one, right?
6.
So at the end of the 31, at the end of the report for the plan, because if there was something found, the plan would be different.
Okay.
Find it?
I thought I did, but then when I'm reading the excludes part, I think can't tell. When I went to convert, I thought I had it, and now I'm not sure if I had the right one.
I'm going to take it for the ladies' room.
Should there be 5 codes to this one?
No, just 2.
2. Got 3. I think it's this right here.
All right, so you should have started in your neoplasm table and done it by the anatomy. So we know that this is in the intestine. So you should be on page 1454 for neoplasm of the intestine. And underneath intestine, you'll see large, and then it gives you appendix, cecum, colon, contiguous sites, hepatic flexure, ileocecum, sigmoid flexure, splenic flexure. Then it tells us small. All right. So we know that we want large intestine. And we also want colon and rectum. And then for the first code, you're going to look at colon and rectum, and we know that it is benign. So you're going to go over underneath the column for benign, and it tells you 211.4. Then you would go into your tabular and look at 211.4, and it falls under the category for benign neoplasm of other parts of the digestive system. And it says rectum and anal canal, and it gives you anal canal or sphincter, anal or anus not otherwise specified, and rectosigmoid junction. So Angel, you just got back, right?
Yep.
So page 1454, we started in the neoplasm table.
Yep.
Intestine, large, colon, and rectum. Go over to benign, and you get 211.4. And then you go in your tabular to confirm page 240, and you should see 211.4 is rectum and anal canal. So 211.4 would be the first answer. And then for the second one, it's cecum in the large intestine. So large, cecum, over to benign, 211.3. And then back in the tabular on page 240, 211.3 is the colon, and it tells you appendix, cecum, ileocecal valve, and large intestine not otherwise specified.
Okay.
Okay?
So that's why you have to give it its own code?
Yes, because they gave you the colon and the rectum and the cecum.
Okay.
Remember, they're different parts. All right, next one, 96. 96 is report 33. And this one is actually pretty straightforward. The pre and post-op is a Fournier's gangrene. We learned about how sometimes diagnosis codes are named after people. You really don't have to go any further than this, except to look up Fournier's gangrene. But you also, in the post-operative diagnostics, have gastric foreign bodies. So you would have two codes here, but the first one you would look up is Fournier's disease. And who can tell me what would be the second thing we would look up?
Foreign body.
Right, foreign bodies. So start with the first one, Fournier's disease, and then do foreign body of the stomach.
It would be the foreign body.
All right, for the first one, Fournier's disease, 608.83. The next one was foreign body of the stomach, 935.2.
Of the stomach, I was looking all over the wrong place.
Right.
Did you look
Because-
up stomach first?
Yes, foreign body of the stomach. How would you know it's of the stomach?
Because it was located.
Yes, first.
Gastrostomy. Yes.
I'm just having a hard time finding.
I blew that one.
All right, number 98 is report 36. Page 234. They're telling you what the preoperative diagnosis is. They're telling you the postoperative is the same. There was an expressed desire of the operating gynecologist to insert indwelling ureteral stents for ease of dissection of the anticipated enlarged adherent uterus. Gynecological diagnosis of pelvic endometriosis. This one is pretty simple. You would do endometriosis of the pelvis or peritoneal. Okay. So just write that beside it. Endometriosis, pelvic or peritoneal. And the code for this.
Six 17.3.
617.3. Number 100 is report 41. Page 237 in the back of the workbook. Number 100 is report 41. The pre and post-operative diagnosis is left cervical spondylosis, C5-6, C6-7 with cervical discs. So you would look up spondylosis. Spondylosis of what? Of the cervical. You should have for that code (721.0). Spondylosis cervical. 721.0.
Did I spell it wrong?
Possibly.
Why do I have 75619?
That's what I have.
Look at 75619 and look at 721.0 and tell me why. What is the category for 756? Read me the category.
Maybe I am spelling it wrong.
No, I got the same thing.
Yes, I am. It's got an extra L. Jeez.
What did you get for the category? What is 756 category?
It's the spondio, but it has LOLYSIS.
So that is a spondylolisthesis,
Yeah.
not a spondylosis or spondylosis.
So what did you say it was?
721.0.
7. That 2 of you were talking.
721.0.
Okay, thank you.
You're welcome. So there's a spondylosis and a spondylolisthesis. Okay? Yes.
It has a stone in it.
Right?
Lithophilus, yeah.
Yes. Okay. Let's take a quick 5 minutes here, and then we'll jump right into 13 and 14. My goal tonight is to hit some of those reports in the workbook. So we might not get to all of the answers. I'd rather focus on the reports and then maybe send you the answers in an email if we need to, okay?
Yep.
Does that sound good to everyone?
Sounds good.
Okay.
My children decide to pass the plague on. Ridiculous it was. It's actually, they're on break. I don't know if you want to mess with anything to try bringing it up while they're not out there.
I don't see it. I honestly don't, because I'm afraid I'll disconnect you.
Oh. Bad time.
Diane knows that.
No. So different, yeah. And she was trying to adjust it and couldn't. And then
Tell me, has
they're
that?
supposed to call me, whatever.
Yep.
Records us later. It's got to be muted. I don't know if it will change anything, but it says I'm muted there.
Lost the contact.
My
Okay, are we all back?
Yeah.
I'm here.
All right. So let's turn to page 360 in your textbook. We'll talk about the CPT book. The CPT book, just like the ICD-9 book, is also tabbed. As you can see, I have it by numbers. In the front of your book, you had some of these flags. And it tells you, where to put them in the book. And I tried it this year by putting the flags in, and then I also put the numbers. And the numbers for me tell me the section of the procedure code and what they start with. Because as I said before, we're looking up codes, we're not usually looking up names, right? So if we know we're going to the index, in the index obviously we're going to start with the word, but we're going to go into the tabular and confirm the code just like we do in our ICD-9 book. So in your CPT book, you should have one like this, and it will say 2015, and you'll notice in the front, here on the left, you have a listing of modifiers. You also have, on page 645, is a bunch of modifiers. And I have a tab at the top that says Appendix A Modifiers. Yep, page 645, I believe. Double check. Do you have your book?
I wrote it down.
Okay. So Appendix A is your modifiers.
And you said that was page 645, Appendix A.
I believe so. It might be a page off or something
It's
in your book.
679, I think. It's 679.
Okay, so
Yeah,
679
679.
is your Appendix A and its modifiers. Okay?
Yep.
So, what is the purpose of assigning a code to a service or a procedure? What do you think, Darla?
What is the purpose of it?
Right.
To, I have the answer. It's to keep it all on a clear, concise form. To keep it all the same everywhere.
Right.
Okay.
Because medical coding basically is transforming services, procedures, supplies, and drugs into CPT and HCPCS codes. Okay? That's what we're doing. So when you get your HCPCS book, it might look like this. It might look like your ICD-9 book. It also might look similar to your workbook. It might be a big one like that, or it might be a small one. But it will say HCPCS on it. Okay? And then what happens is that the medical coding, once we have the full picture, transforms the diagnosis and the procedures into diagnosis codes. All we're doing is we're taking the written word and we're putting it into codes. Okay? So there are levels of service codes. You have your level 1, which are your CPT codes. These are, you have 2 categories. Category 1 are your codes 99201 through 99607. And can we just mute the microphones for now, please.
I don't know how to mute mine.
Are you on a desktop or a laptop?
Desktop, but I have a, it's all by itself. I bought it and put it up there.
So when
It's a
it,
long
when
deck.
it connects to your computer, on the taskbar on the bottom, over on the right, there should show you microphone.
Actually, right there.
Now, as I told you with your ICD-9 book, the same thing with your CPT and your HCPC book. You want to look through the contents, the table of contents at the front of the book, which is Roman numeral 4. You also want to read the introduction so that you become familiar with the format of the book. It talks about the section numbers and their sequences, how to use the CPT book. It talks about category-specific requirements, the guidelines, your add-on codes, your modifiers, the place of service and facility reporting, your unlisted procedures and services, your results, your special report, your time, and your code symbols. It also talks about the alphabetic reference index. And then over on Roman numeral 17, it gives you an indication of the illustrated anatomical and procedural review. It gives you prefixes, suffixes, and roots with numbers, surgical procedures, and conditions. If you turn the page, Roman numeral 18, you'll see it gives you directions, anatomy references. It tells you the anatomical illustrations, and over on Roman numeral 19, it gives you a listing of procedural illustrations. Turn the page to Roman numeral 21. You'll see the body planes. It gives you the 3/4 view, the side view, and the front view. Roman numeral 22 gives you a listing of the psychiatry changes for the year. Then it has a page in there about, AMA and bookstores. And then you should have an evaluation and management table or set of tables. And it goes through every type of E&M, and it lists the types of components and factors that you need. When we talk about the E&M codes, we will refer to these tables. So you want to get familiar with all of your books, just like we talked about the ICD-9. So in the CPT book, you have level 1 CPT codes. Category codes are 99201 through 99607. Your category 3 codes are 0019T through 0339T. Then you have the level 2 codes, which are your HCPC codes, and these are national codes. And they start out with an alpha character, and they end with 4 new numbers. So you'll start with A0021 and end with V5364. Your HCPC codes are your DME codes, your Medicare codes, items that aren't usually covered. And then the level 3 were local codes, and these were actually phased out due to HIPAA. So diagnosis codes. Your diagnosis codes are the ICD-9 codes, and as you know, October 1st of this year, we're going to ICD-10 codes. ICD stands for International Classification of Diseases. The 9 or 10 stands for the number of revision, so the 9th revision or the 10th revision. And then CM stands for clinical modification. So why codes? Why are we going to put it all in codes? Why don't we just continue to type up the reports and send in these reports? Well, after reading some of these reports from Chapter 12, do you think you would know what you're paying for? Okay. Computers understand numbers, and there are specific descriptions that are attached to each code, whether it is a diagnostic code or a CPT code. And a CPT stands for Current Procedural Terminology. CPT was developed by the AMA in 1966. It was updated in November for use as of January 1. It's updated every November, which again is why we have such a difficult time getting our books in the fall. As I indicated, the CPT book is divided by category 1, 2, and 3. Some examples of types of CPT codes, as you have seen already, I know you've all looked through your books. Medical codes, surgical codes, diagnostic services, anesthesia. Your category 2 codes are for performance measuring, and your category 3 codes are for emerging technology. So what do CPT codes allow for? They allow for the communication that is both effective and efficient. It is really a mechanism for us to report a service that is not described by a specific CPT or level 2 code. So I want you to consider this just for a moment. We read a bunch of reports, and then we looked up the codes. So consider a patient comes in for a renal endoscopy through nephrostomy or pyelotomy, with or without irrigation, installation, or uretropylography, exclusive of radiologic service, with endopyelotomy, which includes a cystoscopy, ureteroscopy, dilation of the ureter and ureteropelvic junction, and insertion of an endopyelotomy stent. Where did I lose you? Probably at pyelotomy,
I happen to
right?
have had that all done to me.
Okay.
That's removing the stones out of the kidney, yeah.
Yes.
Yeah.
So if you read that and you're a layperson, you have no idea what they did, unless they just simply told you, we're removing stones out of your kidney. Or you simply put on the claim form 50575, and that describes what you just did to that patient. This is how we tell the payers what was performed. And the diagnosis codes then tell why. Your codes are often used as the basis for payment. So if you have incorrect coding, this will result in the providers being paid inappropriately, either over or under. It will decrease the cash flow, and it can have a liability risk. Your codes are used by clinics, hospitals, rehab units, ambulance services, and long-term. Wherever healthcare services are provided, that is who uses codes. Can I help you? Help desk, can I help you? Your outpatient services for physicians are reported electronically in billing systems, And on paper, it is the CMS 1500 form, which is a universal paper form. As you can see, there is a copy of a CMS 1500 form in your book on page 362. We also had some in the Fordney book that you saw. So the format of the CPT manual on page 363 in your textbook. There are symbols in the CPT book just like there are in the diagnosis book, and these are used to convey information. As I said before, you want to read the beginning part of your CPT book, the introduction, so that it will give you some information about what is in the book. Okay? There's a bullseye in the book, and a bullseye means that it's moderate conscious sedation. Moderate conscious sedation is included, and you will see that there's a full list in the Appendix G of your CPT book. So code 45391 is colonoscopy with endoscopic ultrasound exam. That code includes moderate conscious sedation. When you see a lightning bolt, that means that there is pending FDA approval. You'll find these codes in Appendix K. So code 90650, HPV vaccine, types 16, 18, bivalent 3-dose schedule for intramuscular use. That would have a lightning bolt next to it because it's pending FDA approval. Your bullet means that there is a new code. And if you look at figure 13-2 in your book, it gives you an example of a bullet. Figure 13-9, you have a pound symbol. And that pound symbol means that there's a resequenced code. It might be out of order. The triangle is a revised code. You'll find the triangle on page 364, figure 13-13. This means that they changed the code description. When you see the right and left triangles together, this is the beginning and the ending of text change. So you'll see in figure 13-4, pacemaker or pacing cardioverter defibrillator. They changed the text that was in between those two. A plus sign means that there's an add-on code. You'll see that in figure 13-7 in your textbook. An add-on code can only be used with another specific code. An add-on code can only be used with another specific code. You would never use an add-on code alone, and all of your add-on codes would have a plus sign in front of them. It does not mean a reduction for multiple services. You'll find a full list of your add-on codes in Appendix D of your CPT book. Now, you don't need to tab your appendices if you don't want to. They're not usually referenced that much, and I think I've used mine once in the whole number of years I've been teaching, so you don't have to tab your appendices. You can put one tab to say, you know, these are all of them. The only one I do tab is the modifiers. A circle with a line through it means that 51 cannot be used with these codes. You'll see that on figure 13-8 on page 366. Your Appendix E will contain a listing of all of the 51 exempt codes. This means that services typically are exempt from multiple procedure reductions. Just a straight circle means that it's a recycled or a reinstated code. That means that we used it once before and they're bringing it back. I've already mentioned the appendices. I'm just going to tell you what they are quickly. Appendix A is your modifiers. I would tab this one. Appendix B is your additions, deletions, and revisions. C are your clinical examples of E&M codes. This is a good place for you to review any E&M code examples, real world examples. Appendix D are your add-on codes. E, 51 exempt codes. F, 63 exempt codes. G includes moderate sedation. H are your performance measures, category 2 codes. I, genetic testing modifiers. And J is the electrodiagnostic medicine listing of sensory, motor, and mixed nerves. Appendix K, product pending FDA approval. L is your vascular families. This one you might want to tab for cardiovascular when you're doing that. And Appendix M is a list of all the deleted CPT codes. Appendix N are all your resequenced CPT codes. And O are your multi-analyte assays with algorithmic analyses. So in 367 in your textbook, it shows you the 6 sections of the CPT book, and they are like chapters. The first section is the E&M. E&M is evaluation and management. 2 is anesthesia. 3 is surgery. 4 is radiology. 5 is path and lab, and 6 is medicine. You also have category 2 codes and category 3 codes, and then your appendices A through M. And then you have the index. So you want to put a tab where the index starts. And I have my index tabbed with the alpha tabs. So I can go to my alphabetic index quickly for A through Z. You will find that every section of the CPT book, if you look at the top of a page, let's take and go to because I want to find it, I can't find it. All right, go to find the nervous system in your CPT book. I have my book is 340. It says nervous system, top left-hand corner. So
Mine says 352.
Okay, great. Page 352, top left-hand side says nervous system. So their CPT book is going to be categorized first by section. So the section is going to be surgery. Up at the top left, it says 61000 through 61322. The section is surgery. The subsection is nervous system. Then you have the subheading, which is what you see in red: skull, meninges, and brain. That is your subheading. And then your category will be what's in blue: injection, drainage, or aspiration. So the green is your subsection, nervous system is your subsection. The red is your subheading, skull, meninges, and brain, and the blue is your category. And then you'll see it goes by anatomy, so the knee or the shoulder. Here it tells you skull, meninges, and brain, and then if you were to continue over, it would say skull base, and keep going, stereotaxis, keep going. So every section of the CPT book will be broken up like that. So you'll see it goes by the anatomy first, and then by the procedure. So what is the procedure being done? Is it an incision or an excision? What's the condition? Is it a fracture or a dislocation? What is the description? Is it a cast or strap? Remember how I mentioned earlier, when you're reading these reports, to be the detective. Ask yourself, okay, what's the part of the body? What procedure are they doing? What's the condition that's going on? What's the description? What is the surgical approach? It might be the anterior cranial fossa or the middle cranial fossa. Okay, so you'll see in your textbook, figure 13-6, on page 365, they talk about office or other outpatient services. For a new patient, 99201, the clinical examples are by specialty and area. So they show you here anesthesiology and ophthalmology and pain medicine. Your surgery guidelines over on page 369. Every section will have a specific set of guidelines to begin each section. You're going to have notes throughout all of the sections. You're going to have blank space and white pages. I want you to use them to make notes, like I mentioned before. The notes throughout, you should be reading them, just like I said before in the ICD-9 book. There are two types of codes. There are your standalone codes, which means that you have a full description, and then you have the indented. The indented means it's dependent on the preceding standalone code. Just like with the ICD-9 book, when you see red, a red box or a red dot, that means you need more digits. Well, same thing with CPT. You need to look at the standalone code first and then see if there's anything indented below. Your verbiage before the semicolon applies to all of the indented codes that follow. So some types of codes, if you look on page 370, 13-14, you'll see what I'm talking about with the standalone code and the semicolon and the indented code. With your semicolon, it indicates that there's a full description in preceding code, so you must return to that standalone code for the full description. Just like with our diagnostic codes, look at the main category first. What is it? Your modifiers, they add information. So there are CPT modifiers. They're usually 2 digits, such as 62 for indicating that 2 surgeons perform a surgical procedure over on page 372. Each surgeon would apply his or her individual skill, and then each surgeon would bill the procedure with the modifier 62. Level 2, again, those are your HCPC codes. AS would be your physician's assistant. F1 would be for the left hand, 2nd digit. All of your modifiers used are on CPT or HCPCs. Some examples that we might use would be gastrojejunostomy, 2 surgeons, 43820 modifier 62 indicates to the payer 2 surgeons actually perform the service. The 62 modifier may be allowed based on the payer, but it also, you want to make sure you submit documentation. Where do the modifiers go on the CMS 1500 form? They go in box 24D. Your unlisted services on page 373 in your textbook, you might have codes that end in 99. This means that no specific category 1 or category 3 code, and it is used if there is no more specific code to be used. When you see a code that ends in 99, it means you need a special report. It needs to accompany that claim. As I said earlier, your category 1 codes will start with 00100 and end with 99607. These were approved by the AMA and the Food and Drug Administration. And why? Because they were proven for clinical effectiveness. The category 2 codes on page 374, these are your supplemental tracking codes. These are used for your performance measures. They help to collect data that's concerning quality of care. Your alphanumeric codes, they end with a letter F. So the tracking codes, they're alphanumeric and they end with the letter F. So when you see codes that end with a letter F, these are your category 2 codes. So when you tab the category 2 section in your CPT book, I would name it category 2 and I would put on it F codes. Ends in F. Category 2 codes end in F. Your category 3 codes are your new technology codes. These are your temporary codes. They usually last up to 5 years. They help to identify any technology, services, and procedures. And you'll find that these codes are located after the medicine section. They are also an alphanumeric code and they end with the letter T. So I would tab this category 3 codes, ends with T. And your category 3 codes, these just simply have not been approved and have no proven clinical effectiveness. Yes,
Can I get you to clarify the 99 one more time? Does it,
sure.
can I just put this in my own words that if it ends in 99, it's an unlisted procedure? Okay.
And it needs a report. All right, on page 377, special or written reports, they should indicate the nature and the extent, and the need and the time. Would also include the effort and what type of equipment was used. And if you have photo and medical journals that are relevant, you would include those as well. So let's talk about the index on page 377 in your textbook. The index, like in the ICD-9 book, is used to locate the service and procedure terms and codes. This will help you to speed up the code location as long as you use it like a dictionary. Your first entries and last entries. So on figure 13-8 on page 378, you'll see what I mean by first entry and last entry. First entry is the iris. Last entry is the toe. So what are we repairing from? The iris to the toe. So you know when you're looking up in the index, on this particular page, you're going to start with iris and somewhere over in the other column end with toe. So you're going to see everything in between. Okay? The presentation of the codes in the index, you're going to see single codes just listed by themselves. If they are multiple codes, they will have a comma between them. And if it is a range of codes, you will see the hyphen. So location methods for some of these. If it is, let's say, a service and procedure, we might see that as a repair and an excision. If it is an anatomic site, you might see median nerve and elbow. If it happens to be a condition or a disease, you might see cleft lip or clot. If it's a synonym, you might see toe and interphalangeal joint. So on page 379 in your textbook, it gives you the term practice that you need. If it is an eponym, you will see Jones procedure or Heller operation. And on page 380, if it is an abbreviation, you will see ECG or PEEP. Okay? So these are how you will be looking things up as well. If you want to make sure that you always reference the index first and then locate the code in the main portion of the CPT book, just like we do in the ICD-9 book. Read the entire note and the description. You okay?
Oh yeah, sorry.
On page 381, C in the index. What does that mean? It is a cross-reference term. It means look here for code. In the index, if you see the stem, comma, brain, it will say see brain stem. So then you go to brain stem. Your HCPC book, it is the Healthcare Common Procedure Coding System. It was developed by the Centers for Medicare and Medicaid Services, formerly CMS, or I should say it is CMS, but it was formerly HCFA. HCPCs were developed in 1983. The CPT did not contain all of the codes necessary for Medicare services reporting, and that's why it came about. Your levels of code, as I mentioned earlier, level 1 is your CPT, level 2 are your HCPC codes. Your HCPC codes are also known as your national codes. On page 382, the national codes, there were a wide variety of providers and physicians, dentists, orthodontists, temporary codes for Medicare. So for these codes, you had to have a wide variety of services. Then there was specific drugs, DME, ambulance services. So that's what you find are in your HCPC codes. So many payers might require HCPC codes, and the only way you're going to know is when you get into that job and find out what you're doing for work. Are you using HCPCs? If so, what kind? Each year, the number increases for HCPC codes. You might see injection codes or J codes. J0585 is Botox. You're going to find that the format for the HCPC starts with a letter and it's followed by 4 digits. E0618 is an apnea monitor. Each letter represents a group of codes. Your J codes report drugs and dosages. You even have temporary codes. Your temporary codes will have certain letters such as G, K, Q, S, H, and T. So a heavy-duty wheelchair would be K0006. The HCPC codes are published every January, hence, again, why we don't have one yet. But codes are added, deleted, and revised throughout the whole year. So how do you keep up with them? You follow the bulletins online. So the coverage for HCPC codes, just because there's a code does not mean that it is covered. You will have to call on it and make sure. So just because someone has a hearing aid doesn't mean it's covered. And it's especially not always covered under Medicare. So where would you find HCPCs used? They would be in outpatient settings, including your outpatient departments in the hospital. Your level 1 and your level 2 would be to report outpatient services to certain payers. Just like in your CPT and your ICD-9 book, the HCPCS index is where you start to look for things. It directs you to the specific codes, but like the CPT and the ICD-9, do not code directly from the index. There will be occasion when we're doing work in class where I'll allow that, but I really want you to be in the habit of looking in the index and then confirming in the tabular. You'll see figure 13-22 in your textbook. Where is it? 13-22.
It's 386.
Thank you. 386 gives you an example of what your HCPCS index looks like. It's in alphabetical order. You have the main terms and then you have the subterms. There are even HCPC modifiers. When you get your HCPC book, you will also put a tab where the HCPC modifiers are. Your CPT and HCPC modifiers are used with both HCPCS and CPT codes. So you want to make sure that you tab the HCPC book, okay? Tab the modifiers. You will have anatomical modifiers. You do have them in the front of your CPT book, but you will want to tab the modifiers in the HCPC book. So the left hand would be F, the right, F1 through F4. FA is the thumb for the left hand. F5 is the right hand thumb. F9 is the right hand fifth digit. Some of the often used HCPCS modifiers are LT and RT. LT is left, RT is right. When you're doing a biopsy for a kidney, if they indicate RT, then you would use 50200. Now, one of the issues that happens in this class, and I will repeat it probably again, if it says right kidney biopsy, there are sometimes codes that indicate right or left. You have to just be aware of it. Read the code description. If in the exercise it says right and left, then yes, you want to try and put RT and LT. But again, just pay attention to the code description. Your ambulance modifiers usually indicate the origin and the destination used in combination. The first letter will usually be the origin, the second letter will be the destination. So R would be residence, H would be hospital. Your table of drugs. On page 387, figure 13-26, you'll see a table of drugs there. It's usually listed by the generic name. You will also have durable medical equipment. These are used with chronic disabling conditions. Medicare and Medicaid pay for some DME items, so your physicians first must have to fill out a certificate of medical necessity. Your home oxygen therapy. Medicare may also pay for oxygen with certain medical conditions, but if that's the case, there is a form that the physician has to fill out. It's CMS 484, and they show you on page 390 and 391 what the doctor has to fill out. All right, any questions with that?
I had jotted one down while I was reading through this.
Okay.
One of the symbols is listed in the CPT book, but it's not listed in our textbook. It's the circle that has the arrow going through it. I didn't know if that was like major.
It's not in the CPT book?
Not under our symbols.
It's in the cover of your CPT book.
I mean the cover, yeah, but it's not in the textbook. I didn't know.
That's okay.
Okay.
Yep, that's fine.
Okay.
All right. Did everyone do the review and practical?
Yep.
All right, so page 394 in your textbook, review and practical for chapter 13. Number 1, current procedural terminology. Number 2, category 3 codes. Number 3, revisions. 4, unlisted. 5, guidelines. 6, category 2 codes. 7, modifier. 8, appendix A. 9, special report. 10 is B. 11 is D. 12 is hyphen. 13, section. 14, subsection. 15, subheading. 16, category. 17, lightning bolt. 18, K. 19, I. 20 is modifier 76. 21 is modifier 54. 22, 47, and 23, 50. 24 is 67599. 25, 45999. 26, 40799. And 27, 20999. Number 28, the example has one code. Number 29 has a comma between the two codes. 30, it has a hyphen between the two codes. 31 is C thyroxine, comma, total. They wanted you to tell them what was the section or where you found it. 32, C sex hormone binding globulin. 33, C arm, lower, elbow, ulna. 34, see physical medicine, therapy, and occupational therapy. 35, 49900. 36, 35907. 37, 36147. 38, 51040. 39, 27238. 40, 41874. 41, 44010. 42, J1650. 43, L6900 hyphen L6915.
Could you repeat that one?
Yes, 43, L6900 hyphen L6915.
Thank you.
You're welcome.
These are the ones that were in the hip pick books, right? So I didn't do these because I didn't have it?
That's fine.
Okay.
44, E0630. You can just write these down on separate paper so that when you get the book, you can do them.
Yep. Okay.
45, T5001. 46, V5362 hyphen V5364. And that's V as in Victor, not B as in boy. 47 E1300 hyphen E1310. 48 V as in Victor 2785. 49 L1700 hyphen L1755. And 50 A4261. Let's go to the workbook. Page 73 in the workbook. So 1 through 4. Remember, you have the odd numbers in the back of the book, so I'm going to give you the even. One through 4, any of the following you might have: service or procedure, anatomic site, condition or disease, synonym, eponym, and abbreviation. So 1 through 4, you might have any one of those. Number 6, A. 8 is C. 10 is special report. 12 tells you that the code description has been changed, revised, or modified since the previous edition. "14 is an indented code. 16 is exactly. 18, November. 20 is modifier 51 exempt. 22 is letter D. 24 is E. And 26 is B. Now, underneath the practical, for the radiology codes for 28, you should have 77799. For 30, 77499. Cath and Lab 32, 81099. For medicine, number 34, 96999. All right, let's go on to modifiers, chapter 14. Before we do that, any questions on 13? Okay, so chapter 14 is modifiers. Page 398 in your textbook. Now you notice in your index, Appendix A in your index, Appendix A in your CPT book. Turn to Appendix A. I think you said it was 640 something, 679 or something like that. Just turn to Appendix A, which are your modifiers. You can just follow along in your book. All right, so your CPT modifiers. These are used to describe any alteration to the CPT code. All right, and you will have a full list of the CPTs in Appendix A. What are the modifier functions? They are altering the code to be more or less, to be bilateral, to be multiple, or only portions of the service, such as professional service only, or to indicate more than one surgeon, or an unusual service. So we're going to start off with modifier 22. Modifier 22 tells us that this is an increased procedural service. It indicates that the service is significantly greater than usual, and it will be accompanied with a written report to support what was done. It will also describe the increased physician work. Turn the page in your textbook. Modifier 23, unusual anesthesia. This is the use of anesthesia where no anesthesia or local would be the norm. So if we have a patient who is highly agitated, this is where you would use a modifier 23. It would only be used with the anesthesia codes. So modifier 23 is only used with anesthesia codes. It would also require a written report with submission. Modifier 24. This is an unrelated E&M service by the same physician or other qualified healthcare professional during a post-operative global service. So if the E&M service is not related to the surgery, it can be separately billable, and you would use a code and then the modifier 24. So an E&M code and a modifier 24. If the E&M is provided during a post-op global period, there would not be a separate E&M related to the surgical procedure. So a patient comes in, they had surgery, let's say 60 days ago. Now they are originally coming in as a follow-up to that surgery. If they come in and there's nothing else wrong and it's truly a follow-up for that surgery, you would use 99024, I believe it is, or 99024, which is a follow-up E&M code. If for some reason they're coming in for their follow-up surgery but something else is going on, so the doctor quickly looks at how they're doing from their surgery, makes notes in the chart, but then also takes care of what else is going on. They would use the appropriate E&M code, such as a 99212, with a modifier 24. Okay. '25 modifier is a significant, separately identifiable E&M service by the same physician or other qualified healthcare professional on the same day of the procedure or other service. So documentation must support this service. Let's use an example where the patient is seen for sinus congestion. The provider performs an H&P. He prescribes a decongestant. he notes the lesion on the back, and he removes it. So you're going to code the E&M with a 25 modifier. Okay? And then you can also code the fact that he removed the lesion on the patient's back. Another one would be a patient is seen for consultation for pain management. And then subsequent to rendering an opinion, he was given a nerve injection. So you would place a modifier 25 on the E&M code. And then also code the nerve injection. 26 is your professional component. You also have a TC, which is the technician or technical component. The professional component is the physician. The TC is the technician. If you want to make notes about your modifiers, you should be doing it in your CPT book. So let's say a radiologist reviews x-rays. You're going to use a modifier 26 on that x-ray code. If it's taken by a supervised technician, you would do a TC on that x-ray code. Page 404, 32, mandated service. This basically is mandated by the payer, which might be workers' comp or an official body. It is not something that the patient or the patient's family or another physician can request. Workers' comp might request it on an exam on the person who's currently receiving disability benefits. 33 is preventative service. This is under the Patient Protection and Affordable Care Act. This is basically coverage without cost. 47 is anesthesia by surgeon. The physician administers regional or general anesthesia, so the physician acts as the surgeon and the anesthesiologist. 47 is only used with surgery codes. So make a note by your modifier that this is only used with surgery codes. There is no separate payment when it's used on Medicare patients. Modifier 50 means bilateral procedure. What do I mean by bilateral? It might be procedure on the hands, procedure on the feet, ears, okay? But be cautioned. Some codes describe bilateral procedures in the cases, and when that happens, do not apply the modifier 50. Just like I said earlier with RT and LT, same thing with modifier 50. If it's in the code description, do not use modifier 50.
So if it doesn't say bilateral, how would we write the code? We would write two separate codes, LT, then whatever the number is, and then comma RT?
No, you would write out two separate codes. But more often than not, if it's both hands, it's going to be bilateral.
Okay. But we wouldn't put a comma. We just write two separate codes.
Right. If you're using LT and RT, yes. Because you have to put two separate codes. You can't put the two modifiers on the same line.
Okay.
Not in that instance. 51 modifier is for multiple procedures, meaning 3 types. So you might have the same procedure on different sites, such as multiple lacerations being repaired. You might have multiple operations, same operative session, or procedure is performed multiple times, such as trigger point injections. The 51 multiple procedure also, you want to, when you're using the 51 modifier, list the most resource intense first. So the highest RVU value first. then the other procedures. Unless, of course, the code is 51 exempt or an add-on code. Usually, the method of payment, the first procedure is paid at 100%, the second at 50%, and the third at 25%. The first procedure paid by Medicare is usually 100%. The second through 50%, more than 5, they're priced manually. The 52, reduced services. The service is reduced from the code description. This is usually directed by the physician to reduce it. Your documentation would substantiate the reduction. This is not for patients who are unable to pay the fee. Make sure that you submit the full charge to the insurance so that the payer can adjust it. Let's see. On discontinued procedure, page 411, this is where surgical and diagnostic procedures usually are started and then stopped, maybe due to a patient condition. This does not apply to any pre-surgical discontinuance. You would not use modifier 53 when the patient cancels the scheduled procedure. You would not use 53 with an E&M code, and you would not use 53 with a time-based code. Your modifiers 54, 55, and 56. 54 is for surgical care only. This is where your physician provides only the procedure, which is the intraoperative. It is then documented that the patient is transferred in the record. Some of your payers might actually require a copy of the transfer. Your 55, postoperative management only. This is where your physician provides only care after the hospital discharge. So if the patient is transferred while he's hospitalized, your report post-op will indicate such, and then you'll have subsequent hospital codes. So the physician might see him outside in the office. Again, your documentation of transfer needs to be in the medical record. Modifier 56, preoperative management only. This is where the physician provides only the preoperative care. This is not an acceptable modifier for Medicare. They require the surgical code with the modifier 56. Your surgical packages. The usual reimbursement for your surgical packages is that 10% is preoperative, 70% is intraoperative, and 20% is postoperative. What happens is that each payer will determine the portion that they're going to pay. Modifier 57 is used when the decision for surgery is made. So you would use the E&M code and then the 57 modifier. Medicare only Medicare only pays for the pre-op period of the major surgery, which is the day before or the day of. They do have a 90-day global period. Modifier 58 on page 414. This is a stage or related by the same physician or other qualified healthcare professional during the postoperative period. This is where subsequent procedures planned or related to the first surgery. So during post-op of the previous surgery in a series. If you have multiple skin grafts that are completed in several sessions, this is where you might use modifier 58. When you do that, the global period starts over. Okay? Do not use modifier 58 when this code describes a session such as 67208, lesion destruction of retina, one or more sessions. When it actually comes out and says session, do not use modifier 58. 59 is a distinct procedural service. This is for a different session or encounter, a different procedure, a different site, a separate incision, excision, lesion, or injury. Do not use when another HCPCS modifier is appropriate. Modifier 59 is in the news a lot because modifier 59 is misused. It's one of the most common misused modifiers, and it can actually put up red flags for payers to audit you. So let's say a physician removes several lesions from a patient's leg. He also notes and biopsies a mole of the torso. He will use a biopsy code for the mole plus a modifier 59. He will then indicate the biopsy as a distinct procedure, not part of the lesion removal. Okay? Modifier 62 is for two surgeons. This is where both of them function as co-surgeons, so they are equals. It usually different specialties. And again, each surgeon would report the same surgery code, but they would append the modifier 62, and they would also dictate their portion of the procedure. Modifier 63 is a procedure that is performed on an infant less than 4 kilograms. 2.2 pounds is a kilogram, so 4 kilograms equals 8.8 pounds. The small size would increase the complexity, and you want to use this with all your surgery section codes except the integumentary and those that are exempt by the parenthetical notes. So modifier 63 would be on surgery codes except integumentary and those that are exempt by the parenthetical note. '66 is for a surgical team, usually several physicians with various specialties plus technicians and other support personnel. You would have very complex procedures. The payers may increase their payment. Modifier 76, repeat procedure and service by same physician or other qualified healthcare professional. You want to make a note that it says same physician or other qualified healthcare professional because it's used to indicate necessary repeated service. It's not a typographical error. Okay? So an example of this would be the x-rays before and after fracture repair. Okay, they want to make sure that they got the pin in there correctly or something. Or an aerosol treatment for an asthma attack repeated in 90 minutes. Okay, that would have a modifier 76. Modifier 77, repeat procedure and service by another physician or other qualified healthcare professional. Again, note another. This would be performed by one individual, but then repeated by another one. This would have a written report submitted with it to establish the medical necessity. 78 is an unplanned return to the operating and procedure room. Same physician is following the initial procedure for a related procedure during the postoperative period. So let's say the patient has a complication. So the patient has an outpatient procedure in the morning. They were returned to the operating room in the afternoon with a severe hemorrhage. That would be a 78. Again, this is not a typographical error. And it does not change the global period when this happens. 79, page 420. Let's say several days after discharge for a procedure, a patient returns for an unrelated procedure in service. That would be a 79 modifier. The diagnosis would be different. And remember, if you use an E&M code, you would use a modifier 24. If the surgery is actually unrelated to the original procedure, and then your new global period. Modifier 80 is assistant surgeon and 81 is minimum assistant surgeon. When you have an 80 modifier, they usually will reimburse at 15 to 30%, and in 81, you'll see that services at a level less than that described in the 80 is usually reimbursed at 10%, if at all. And your assistant surgeon is usually seen at teaching hospitals. So they'll have residents who assist as part of the education. So there's no fee. They must demonstrate when you put it in the documentation that no qualified resident was available. If there's unavailability documented in that written report, then you have to indicate who was assisting. Modifier 90 is only used on laboratory. Modifier 90 is for referencing an outside laboratory. This is where the physician has a business relationship with an outside lab. The physician pays the lab. Then the physician bills the payer for the lab services, and you do not use these for Medicare. They cannot be used for Medicare. Modifier 91 is where we repeat the same laboratory test on the same day for multiple test results. So this is not that the tests are rerun to confirm an original test result, and it's not a malfunction of the equipment or the technician error. All right. 92, alternative laboratory platform testing. This indicates a kit or transportable instrument, usually single use or disposable. An example of this would be an HIV test kit, 86701. Then we have 99, which is multiple modifiers. This is where, and this is rare, it is used when services need more than one modifier, but the payer only allows for one modifier with each code. And if you look at page 423 at the bottom of the page, they'll show you that you only have room for 4 modifiers. So what you would do is, if you ran out of room for modifiers, you would then indicate a 99. Okay?
Where would you put the 99? You wouldn't use up all 4 boxes, you'd just write it once, 99.
No, you would put what you would put the first few modifiers, and then put 99.
Okay.
All right, review and practical. All right, review and practical in the textbook. Number 1, team or surgical team. Number 2, what do you have for an answer, Lisa?
No.
Right, no, because a note in the CPT index states modifier 22 cannot be appended to an E&M code. Number 3 is modifier 22. Number 4, intraoperative or surgery. Number 5, it is because she is incorrect because modifier 32 is only assigned for mandated services such as police, workers' compensation, not for requests made by patient, family member, or another physician. 6 is B, 7, B, 8, C, and D. 9 is false, and 10 is A. Eleven is modifier 76. 12 is 62. And 13 is 26. 14 is 99. 15 is 59. 16 is 32. 17 is 25. 18 is 81. 19 is 77. 20 is 79. 21 is 23. 22 is 78. 23 is 54. 24 is 52. And 25 is 66. How many of you were able to finish the workbook?
I only got to 13.
Okay. So again, if you didn't get to it, write your answers on a separate sheet of paper so you can check them over after you do your work. Number 2 is unbundling. Number 4, postoperative services and management or post-op. And number 6, co-surgeons. Number 8 would be none. Residents are not paid. In your ICD-9 code, you would have 414.01. You would have modifier 23. And you would have 3 codes there. The first one would be for a wound on the open lip, 87343. The second one would be an E code for the fall, E888.9. And then E849.0 for an accident at the home. Twelve would be modifier 47. ICD-9 384.20. Because that would be for a preparation of the tympanum. 14 is 78. 16 is 50. And 18 is 22. Make sure you make a note or see the note that says you would not use modifier 63 because the patient weighed more than 4 kilograms. 20 is modifier 80. And 22 is E1.
Could you give me 22?
Yes. It is E1. Edward 1. Now I want to talk about chapter 15. Chapter 15 is all about E&Ms. And it's also when you start in the CPT book, and it is the first section in your CPT book. And you have guidelines that start in the CPT book, so make sure you have your books next week. But when you get to the exercises in the workbook, what I want you to do is to pay close attention to the start of the exercise. Because at the top in bold, it's going to tell you where you're pulling your E&M codes from. Okay? So the first one is office or other outpatient services and hospital inpatient services. So when you find your code, that is the section that you should be under in the CPT book. If you turn to page 86 in your workbook, it tells you consultation services. Again, if you find a code that's not in the consultation services, I'm going to tell you right now it's wrong. On page 90, emergency department services, nursing facility, domiciliary, and home services. That is the section you'll be finding your answers. 92, prolonged services and preventative medicine services. Also, services from throughout the E&M section. This is the only part, number 61 through 68, where you will actually be coding from anywhere in the E&M service. Okay? $15 is long, and it will probably take us all of class to get through. I want to go over just a couple with you. On page 94, number 68. Henry Green, an established patient, came into the office for his yearly physical exam. Henry is 72 and in good health. Now, I know you haven't read the E&M section yet, but this is simply telling you that he is an established patient, he's in good health, he came in for an exam, What can you remember from your diagnostic codes? What type of diagnostic code would you give Henry? He had no services. He just had an exam. He's in good health. It's his yearly physical. It's a V code.
Oh, yes.
Okay? It's a V code. All right. underneath the reports, let's look at report number 2 on page 210. And of the reports, this is the only one I really want you to do. If you want to do the others, go ahead, but I only want you to do this one. Now, it's pretty much laid out for you. They tell you in parentheses what they want you to code, but you need to figure
What
out
page are you on?
210.
Thank you.
But you have to figure out from this report, what is the secondary neoplasm? Okay, what is the CPT code? And I can tell you right now, the CPT code has to do with a discharge. Okay, it's a discharge. Why? Because it says right at the top, discharge summary. Hello? And then it tells you right in the page 95, what codes are you going to do? You're going to do secondary neoplasm, primary neoplasm, vena cava syndrome, catheter complication, hypertension, and nerve pain. I want you to just try it. That's all I want you to do. Read the report and try it. I do not, if you after 15 minutes don't get it, don't do it. I do not want to end up frustrated. Okay? And that's the same with the homework. If anywhere in this homework, in this chapter, you start to feel frustrated, I want you to put an asterisk or check mark next to that question. And what I would like you to do is send me an email that says, Doreen, chapter 15, page whatever, exercise number whatever. So I can have it prepared for class to go over in class. I want you to just move on from that one. Okay? Don't sit there and spend hours upon hours upon hours trying to figure it out. Let's talk it out in class so that we are all learning. Okay? So what is everyone going to do? Darla?
I'm going to jot down the question and send it to you email if I don't understand it or if I don't get it within 15, 20 minutes.
And you're going to move on to the next one, right?
And move on, yes. Yep.
Okay. Angel, what are you going to do?
Don't let it hold you up if you don't understand it.
Yes, because you will get so frustrated. It's not even funny. Okay? Emily, what's your takeaway from tonight besides your head swimming?
I guess this use of the CPT book. Anything like that. How many modifiers there are, boys and not.
Yes, modifiers, number of modifiers blow your mind. And what you want to do is pay attention to the section and how they're being used. Okay? Lisa, what is your takeaway from tonight?
There's all the modifiers from the CPT to everywhere else, and making sure I put them in the right place. It's just a lot to think about.
It is. And what are you going to do for me?
I'm gonna look at them probably 20 to 30 minutes. I'm not gonna lie. And if I have a question, then I'll send it to you.
Thank you very much. Okay. Angel, what is your takeaway from tonight?
A lot of regulations to go with the modifiers and to understand what the categories go with what, for the modifiers. It's a lot.
Okay. And Darla, your takeaway?
I actually kind of like this better than the ICD-9 part. I don't
Well,
know.
wait till we start
well,
using them
yeah.
all together.
The terminology's kicking in. I like that, but where to find everything it's kind of hard for me to trying to pull it together so it makes sense to me. You know. ICD 9. Yeah.
I'm not gonna lie. I'm gonna tell you that now is the time where if the light hasn't, come on, it will. All right. We are only now just starting the coding, believe it or not. You've done mild diagnostic coding. Now we're starting the CPT coding. Okay? This is where we start learning how to put it all together. But we need to learn the procedures first. And then we need to know why those procedures are being done. And then as we get into it, it's, well, is the terminology coming back and the AMP coming back? Where's the bile duct? Where's the biliary duct? When we talked about rectum and colon before and the cecum, where is that? Okay? So this is the time where when you're going to make your notes, I really want you making them in your ICD-9 book and your CPT book. So next week you're going to need your CPT book. Not necessarily the ICD-9, we'll use those later. But this is where we start pulling it all together. This is where, honestly, you can start getting the most frustrated, and I don't want you to do that. I really want you to be able to send me those emails, and let's work them out in class together. Okay? Does that sound good to everyone?
Yep.
Sounds
Yes.
good.
All right. The format going through the reports, was that helpful tonight?
Yes.
Looking up the different things?
Yep.
Okay. So what I want from here on out is when I call on you, I want you to tell us all what page you're going to, where we're finding it, what we're looking up. I want us talking it out loud. To do so, though, we're going to have to try and be a little quiet just because the microphones are picking up every noise. And a lot of the online students are complaining that they can't hear what's happening. Okay? With that, we're going to call it a night unless you have any further questions.
The other program for the hospital billing, who runs that one?
We do.
No, do you do it though? Who's the instructor?
Me.
Yes. Is there a certain time it starts or?
After this one.
And that you don't like you said that you'll get the entitlement within the year instead of having to wait a year out.
Yeah.
I'm looking into it.
Okay. Just let me know.
Alrighty.
All right. Have a great week, ladies. Thank you.
Bye.
Bye.